You, one of the true privileges of this position is being able to invite people who are your personal heroes. And this is absolutely no exception. Dr. Hansel Tooks has inspired me in so many ways, and I admire so much the work he's done. I think, Dr. Tooks, that you embody what John Lewis said when he said, "Don't give up. You can find a way to make a way out of no way." And I think for all of us, it is such a lesson from what you've done to say that we can move the needle for justice. And so with that, I will tell you guys about Dr. Tooks. So Dr. Hansel Tooks is Associate Professor of Medicine at the University of Miami. He completed his residency in internal medicine at Jackson Memorial Hospital, not so dissimilar from Grady. He founded the IDEA Lab, whose mission is to implement, disseminate, educate, and advocate for the health of people who use drugs. The IDEA Lab also houses the IDEA Syringe Services Program, the very first of its kind in Florida. Dr. Tooks, I think starting as a medical student, maybe, spent 5 years lobbying the Florida legislature for the creation of a syringe service program as evidence-based HIV prevention intervention. In 2016, he succeeded from sheer tenacity and from being smart about how the advocacy worked and what the benefits were. And I think counting used syringes on the street by square foot, block, mile, and the pilot was signed into law. Today, Dr. Tooks serves as medical director of IDEA and successfully passed the Infectious Disease Elimination Act of 2019, authorizing statewide expansion of syringe service programs. As a physician at Jackson Memorial, one of the largest public hospitals in the nation, he attends on the HIV service. He's an advocate for health equity and has extensive experience working with both patients of low socioeconomic status and persons who use drugs. Dr. Tooks' research interests include structural and systemic interventions and innovative approaches to HIV prevention and treatment. He's a 2021 recipient of the $2.5 million NIDA Avenir Award, which is for Rising Stars, which will test his innovative teleharm reduction model in a randomized controlled trial. And more recently, 2 NIDA R01s proving his Rising Star, now established star status. He's received numerous honors, including the Miami Chamber of Commerce Healthcare Hero, the Starbucks Upstander, and SAVE Champion of Equality. In 2023, he was appointed to the board of the HIV Medical Association and the Presidential Advisory Council on HIV/AIDS. He is interrupting his duty on the Presidential Advisory Council today to give us this address. So Hansel, thank you so much for joining us. And I'm sorry I took like too long for the introduction, but I couldn't help but editorialize a little bit in there.
Oh, no, thank you so much for having me. That was very, very kind. I love to be with you at Emory, and hopefully I'll get to come in person sometime in the near future. Are you seeing my my title slide?
It looks
Yes?
perfect. It's perfect.
Okay. For those of you who get nervous about not giving presentations in your office, I will tell you, I've been doing this for a while. I still get nervous every talk, but I think that it's more excited. I was able to figure out how to mirror my iPad. So just to let you know, you can mirror your iPad so that you can see your notes as you are presenting, which is always very, very helpful. So I'm going to talk to you about implementing Florida's Infectious Disease Elimination Act, IDEA, and translating research evidence. Oh.
Yeah, we just lost your slides.
We lost my second screen. Right. Let me go back to Zoom. Share screen. So I guess it's not seamless, but I will try to keep the iPad going.
Okay, we've got now your screen, but not your slides. There we go. Perfect.
All right, let's get to the video. This is Miss Sarah.
Listen, there's a place right on the corner of 7th Avenue. And inside our group of people, half of them are recovering addicts, half of them not, but all of them care. So, why don't you go let somebody care about you?
Here on 7th Avenue, right under the sun in Miami, is Florida's pioneering syringe service program, the IDEA Exchange, where tools like harm reduction, advocacy, and compassion are being used to save lives. At the intersection, stories of research, compassion, and HIV services for people who use drugs, addressing barriers to care.
Everything that we do is informed by our participants. So we asked them, what are the barriers? We mapped it out. We had our participants in the room and we said, how do we overcome these barriers?
Hey, we can't just give someone experiencing homelessness meds, not because they're irresponsible, but because homelessness comes with a few variables that can lead to you losing your medications. So in one of these trailers, you're going to see that there's a locker system that holds HIV medications, Suboxone medication for opioid use disorder in there.
Each patient is assigned a number. It's anonymous, but each person has a locker where they can access their HIV meds, their PrEP, their Hep C treatment, their Suboxone. This helps because it gives us the opportunity, because we know how much the patients have taken. The whole thought is to combine everything. Combine antiretrovirals with the provision of naloxone, with the provision of syringes, have a really appealing package so they get everything in a one-stop shop. All right, Ken. So when you enroll an idea for the first time, one of the members of my team, whether that be a peer or one of the other staffs, we bring the client in here. We can offer rapid HIV and hepatitis screening. And the reason that that's so important in Miami is because people have been using substances and having sex for years in the absence of a public health home like the Idea Exchange. So, you know, it would be one thing if we were doing these tests and we didn't have the ability to treat. But we not only test, but we also treat. So we encourage people to get their rapid screenings. 10% of the people test positive for HIV. I think that's probably higher than most syringe services programs, but this is Miami. This is the city with the highest rate of HIV in the country. Now, when we did our investigation of the outbreak, it seemed that a lot of that risk was sexual. And so handing out condoms is a major part of our operation.
So you come here, you get your equipment, you get what you need over here. You get your cotton, you get your alcohol swabs, you get your cookers, and you also can come here and get your condoms as well.
Absolutely. And hygiene products, anything you need. These programs are here and we adapt dynamically just to meet the needs of the people that we serve. We diagnosed the HIV outbreak in the homeless encampment in 2018, had to forge a pathway to care for people who inject drugs who are living with HIV out of nothing because there was no pathway. All of the requirements were insurmountable for somebody who does not inject drugs.
Today, you can get into HIV treatment like within an hour of testing positive for HIV with Dr. Tukes if you're a person who injects drugs. Back then, it took the entire day.
What teleharm reduction does is it builds upon those decades of evidence that it is important to meet people where they are physically, mentally, and treat them with dignity and respect, and just brings medical care into it. So it's a telehealth enhanced intervention delivered via a peer with lived experience. They're able to have on-demand visits. If it's been a while since they've had a visit, the peer will go out and see them. We're able to initiate antiretrovirals. We're able to do labs in the field. We're able to set the traditional healthcare system aside and bring care to the people, just like old house calls. So can one of you go to his house and with the iPad and the hotspot and just connect him with me so I can talk to him? Because his mom died. You know, his real goal was to not use before his mom died, to stop using, but he was not able to. And I think he's really beating himself up about that.
All of my care comes under Dr. Tooks. He has a team. I have 3 social workers that bring me my meds. They get me to my appointments.
It's fantastic. People just they feel safe, and once they are taking their medications, and I tell them, you're undetectable.
Undetectable equals untransmittable. You equals you. The person living with HIV can get and keep an undetectable viral load by taking HIV medication every day as prescribed. If you are undetectable, you cannot pass HIV on through sex.
They're so excited. They have this sense of relief that they aren't at risk of sharing HIV, transmitting HIV to their partners and their loved ones. But also, it's an accomplishment. Like, I was able to do this quickly, like take this medicine and get this under control. And it leads to other things like, oh, maybe now we'll treat the Hep C. If I can take antiretrovirals, maybe I can take Suboxone. And it just grows from there.
I really feel that the most appropriate place to deliver HIV care to people who inject drugs is via a syringe services program, via this trusted institution, the one place in this great city where they don't experience judgment. These ideas that my patients have given me, ideas of how to help them, they're working.
So I think that I will be 70 still including these videos that NIDA produced in my presentations. It seems so obvious and so easy, but how did we actually get there? And so I am going to start by talking about bringing harm reduction to the US South, but I am presenting to folks in Atlanta. So I must take a moment to give true respect to Mona Bennett, who has been slinging syringes in the Bluff for forever. And what's very, very interesting about our story in Florida is that I will tell you, spoiler alert, both Georgia and Florida legalized syringe exchange, but Governor Kemp actually signed the legislation a week before Governor DeSantis. So there is hope, I guess, in the past for bipartisan relations. So this academic medicine paper that I wrote with my dean, Dean Henri Ford, highlights 10 years of my life. I spearheaded the journey to bring syringe exchange to Florida, and it really wasn't a simple task because our political climate is complex, probably even more complex than Georgia, as Georgia has sought to save the nation multiple times in recent years. We authored two key translational studies that showed significant need for these programs, particularly in Miami-Dade County. The first was a syringe disposal study, and Dr. Armstrong alluded to this, where I walked with my classmates through Miami in the areas with the most drug use by arrest data, and we counted the number of syringes, and we found that Miami had 8 times the number of improperly discarded syringes as San Francisco, a city that has had long-standing harm reduction programs and distributes millions of syringes per year. The second study was a cost study. And why did we go directly to cost? Well, I went with a bunch of my classmates as a medical student, drove 7 hours to Tallahassee to file and advocate for legislation to authorize syringe exchange because it's life-saving and it's a very loving and non-judgmental approach to substance use. And the legislators did not care. But they seemed to pay attention when we talked about cost of infections related to injection drug use. So we came back to Jackson and we looked at the ICD-9 codes, and we were able to identify a cohort of about 349 people, and their infections cost Jackson Health System $11.4 million in 1 year. So shortly thereafter, then Governor Rick Scott signed the pilot legislation to authorize the idea exchange. But because the legislature just authorized a 5-year pilot, it was imperative to do rapid evidence-based implementation and scientific research at our program, including statewide analyses, so that we could successfully advocate for expansion of these programs. The reduction in the number of opioid overdose deaths that you see here in Miami-Dade County was our earliest success. And then the outbreak investigation and response was our second, and I'll come to that later. So the Infectious Disease Elimination Act of 2016 authorized the idea exchange pilot in Miami. So why was it called IDEA? It's because I was with my classmates in the Capitol and everybody referred to us as the students there to advocate for the needle bill. So this was our first rebranding. And it's interesting because the name IDEA has stuck. The bill became effective in July of 2016, and it authorized the University of Miami to implement a syringe exchange pilot program. This was an exception to the Florida, the paraphernalia statutes, which made it so that possession, distribution, or exchange of needles and syringes was no longer a violation of the law. It was previously a third-degree felony to give a syringe to somebody that you knew was going to inject drugs. So this was a major change in Florida law. So data from our 2023 annual report, which is our most recent, showed that we have 2,200 people. Our diversity is increasing to better reflect the diversity of Miami-Dade County. We've made many actions in order to improve the diversity of our program. You can see that the mean age is 38. Like many syringe exchanges nationwide, the percentage male participants is 72%. And so also engaging women and engaging the transgender community is a top priority of our program at this time. So what do we offer at IDEA? So we offer anonymous testing for HIV, hepatitis C, and during the pandemic, when that video was filmed, of course, COVID, we offer syringe exchange and access to all of the injection equipment that people need, because we all know that injection equipment also transmits hepatitis C. We offer free condoms, the bread and butter of harm reduction, and first aid kits, a lot of wound care, particularly in the xylazine era. Narcan distribution is our largest success, and education. We have a weekly free clinic that's open to the community. It's run by our students under the Department of Community Service, or DOCS program. We offer on-site linkage to care. So we have HIV care, hepatitis C care. We are able to do medically supervised withdrawal or detox, and also treat people for substance use. Medications for opioid use disorder, the Bright Clinic, where you can see our advertisement to the side. And of course, Dr. Sirota, an Emory IDEA alum, he named this. He's very good at naming things. So Bright IDEA Clinic is the buprenorphine initiation and treatment experience. And I know you all had a chance to hear from my amazing colleague a few weeks ago. Very importantly, we also offer mental health services. We have on-site psychologists and social workers. You saw the pill lockers, medication management, putting medications in the lockers and delivering them to our participants. We offer on-site buprenorphine inductions, as well as linkage to methadone treatment. Our mobile unit launched in 2017. This extends our services throughout Miami-Dade County. Miami is huge. It goes all the way from agricultural areas to the major city core and South Beach, what people normally think of when they think of Miami. The mobile unit goes out. It includes backpacking, where people fill backpacks filled with harm reduction supplies, and they go out and they pound the pavement and go into the tent encampments and really look for our folks. Engaging our participants is becoming even more challenging in the era of frequent city sweeps and gentrification, which has its hooks in the city of Miami. It's definitely becoming more challenging to provide all of the services that we have historically. All right, so on to a little bit of the research. So we have always used data in order to improve implementation. When you look at the paper on the left, led by one of our MD-MPH students, Sid, the mobile unit seemed to attract people who inject drugs from a higher risk and harder to reach community than our fixed site. There were more women, there were more Black folks, there was higher self-reported baseline Hep C positivity. There was lower socioeconomic status, more homelessness, more public injection, and less use of alcohol swabs than at the fixed site. So we all know that the alcohol swab is one of the most important harm reduction interventions, as it is the most effective in preventing all of the bacterial consequences of injection drug use. We also looked at some of the baseline correlates of HIV and hepatitis C infection using our programmatic data. And we found, not surprisingly to all of you in Atlanta and at Grady, that unfortunately, the most significant predictor of HIV infection at our program was Black race. Other variables that were significantly predictive of baseline HIV infection were age, gay or bisexual orientation, Hispanic ethnicity, and methamphetamine injection. So how did we improve equitable reach? I showed you our numbers now that reflect more of the diversity of Miami, though we still have work to do. The numbers in our first year's annual report were quite concerning, so much so that the commissioners dragged me when I presented to the commission our first year data. But it was all in good natured, and I told them that we were going to work very, very hard to improve our engagement with more marginalized communities. So we did three things. We increased our mobile stops in historically Black communities. We hired Black staff and peers. And we really worked to meet people where they were, the fundamental tenet of harm reduction. And you can see here with our mobile unit, we were successful, and we had a surge in the number of Black people who inject drugs that we were able to engage. Overdose prevention is highly successful at IDEA. We offer naloxone to our participants. We offer it to family and friends of our participants. And we also offer it to law enforcement partners. Now, this is controversial, but the bicycle police in downtown Miami love to come and pick up naloxone and tell us stories about how they have saved people. And while controversial, we had to engage with law enforcement so they would stop arresting our folks. And this partnership has been effective. I think that the law enforcement in the city of Miami truly understands harm reduction, so much so that they played a critical role in convincing the legislature to expand the program statewide. So, share Narcan with your police officers if they ask for it, is my advice. We've distributed over 13,000 doses, and we have 3,800 reported reversals. You can see here, Miami-Dade County is green. The rest of the state is bad. This is the largest part of the state. This is Palm Beach, Broward, and Miami-Dade County. And that is just because of our culture of harm reduction that we have the fourth lowest overdose rate in the state. So, idea, research, and evaluation. So I just want to tell you, due to the multi-level complexities of drug policy and substance use disorder, which we all know in medicine is highly stigmatized, we as researchers need to work in a team science approach, leveraging multiple disciplines to innovate and scale harm reduction interventions. Dr. Tyler Bartholomew, a prevention and implementation scientist in my lab, as well as me as a harm reductionist physician, we have complementing expertise leading the IDEA lab. And our mission, as Dr. Armstrong said, is to implement, disseminate, educate, and advocate for the health of people who use drugs. We set the policy context at the center of our work to develop effective strategies and to de-implement ineffective strategies that are harmful. And we want to promote implementation of effective solutions that we know work. And to promote the health of our community of people who inject drugs, our work began with removing the prohibition on syringe exchange programs in Miami and then Florida under the Infectious Disease Elimination Act. Our work then evolved into HIV and hepatitis C testing and linkage to care strategies. And our journey ultimately led to the implementation strategies such as telehealth and our signature teleharm reduction intervention. So the University of Miami IDEA Lab. So we have always used a community-driven approach, including people who use drugs, at the center of design and implementation of our interventions. We've developed new models of care for the treatment of HIV among people who inject drugs through implementing a telehealth infrastructure at the trusted venue of a syringe exchange program. And we conduct research studies to show the effectiveness of syringe exchange at the community and individual level. So we are looking to turn research into public policy. So Dr. Armstrong alluded to the study that I conducted as my capstone when I was an MPH student. I believe I was TA for Dr. Colasanti, who is my esteemed colleague at Emory. And when I was a faculty member, my first year, one of the MD-MPH students came to me and wanted to replicate the syringe disposal study post-implementation of IDEA, which I thought was a fantastic idea. So after IDEA was implemented, we found 191 syringes per 1,000 blocks. Pre-implementation, we had 371 syringes per 1,000 blocks. So this was a 49% decrease in publicly discarded syringes after implementation. It's really interesting because the paper that catalyzed the movement to bring harm reduction to Florida was something so simple as syringe litter. But this work is very, very important in managing public interactions and community engagement because nobody likes syringe litter. In our surveys that were conducted as part of National HIV Behavioral Surveillance from CDC, there were 70% of individuals reported any improper syringe disposal after IDEA was implemented. However, before IDEA was implemented, 97% reported improper disposal. There was a 39% lower adjusted relative risk of improper disposal compared to pre-implementation. So very, very successful. You can see here the number of syringes in circulation in the prior 30 days was 3 times pre-implementation, but the vast majority were returned to the syringe service program or to Sharps containers, which we distribute. We also conducted, from my balcony during COVID lockdowns, a latent class analysis, and we were able to identify three distinct groups of individuals that we serve at IDEA. So people who predominantly inject heroin, that you can see here, people who inject predominantly methamphetamine, and people who inject opioids as well as cocaine or speedball. So compared to people who primarily injected heroin, people who injected heroin and cocaine were more likely to report homelessness, sharing works, unprotected sex, public injection, and to have hepatitis C. In our group of individuals who predominantly injected methamphetamine, this class was most likely to be male, to be Hispanic, gay or bisexual orientation, most likely to have HIV, and most likely to report unprotected sex and sex with people who inject drugs. Finally, when you look here at syringe coverage, which means that somebody has one new syringe per injection, you can see that lowest syringe coverage was among the class of individuals that injects heroin and cocaine, and the highest syringe coverage was among the people who inject methamphetamine. This was a critical analysis because our HIV outbreak was among unhoused individuals who used both heroin and cocaine. So they had the low syringe coverage. And the take-home message is just that one-to-one exchange, which is required in our state law, is ineffective. We've also conducted statewide analyses. You can see your alum, my very amazing colleague, David Sirota, as the first author of this analysis. We conducted a statewide analysis of the Medicaid database, and we found that the economic burden of injection-related injuries in Florida in 2017 was $380 million prior to statewide implementation of SSPs. And using that same cohort, we examined hospital outcomes such as patient-directed discharge, which we often call in medicine against medical advice, and in-hospital mortality. And we found that co-occurring stimulant use significantly increased negative health outcomes among people who inject drugs. So back to our on-the-ground work at IDEA, because I'm sure Dr. Sirota talked to you about his transformational high Siri trial that is underway at many sites to test his intervention for taking care of folks who inject drugs who are hospitalized. Back to our outpatient side of our programming. And so, my iPad is going crazy now because Dr. Sirota named his trial in a way that activates all of our Apple devices. And I'm sure he giggles every time he sees it. So when we look at our opt-out testing policy, so IDEA was our first legal SSP in Florida, and we examined how to best implement HIV and hepatitis C testing and how to best link people to HIV treatment and prevention services. We found that opt-out testing significantly increased testing at our program by 42%. And this uptake was extremely important because this is how we uncovered, investigated, and responded to a growing HIV cluster among our participants. You can see the trend line was already people were more accepting of HIV testing as they came to be more trusting of IDEA. And that trend line has increased even after the—
One moment.
Yeah, that's my Siri going. Thank you, Dr. Sirota. So it was
Still working.
trying to cancel it.
That may be beyond my abilities at the moment.
It's beyond Siri's abilities. So this was very important because this is how we uncovered our outbreak. So we identified 8 acute HIV seroconversions shortly after implementing that new testing infrastructure. Each X here is somebody's negative HIV test. Each red dot is when they tested HIV reactive. You can see here the blue dot indicates viral suppression. And this seems very, very simple, but we had to create a pathway to HIV care for people experiencing homelessness and injecting fentanyl and stimulants out of nothing. There was no pathway in Miami-Dade County. And so we had to forge a strong partnership with the Florida Department of Health. And I have to tell you, this was a seismic shift. The Florida Department of Health had vociferously opposed our syringe exchange legislation in the Capitol. So we had to make up and let bygones be bygones. And we were able to forge a strong partnership. There were preemptive laws that had prohibited any state or local funding for SSPs. But through our public-private partnership, all of the people who inject drugs with acute HIV infections were suppressed, and the mean time was 70 days. It was a mean time of 20 days to initiating care and 50 days after initiating care to become virally suppressed. Importantly, we asked our community how we could best help. And one suggestion to assist in suppression was medication storage on site and deliveries. And this was an amazing idea. And that's how we got the pill lockers that you were able to see in the video. We have always used a community-driven research approach to the development of our teleharm reduction intervention, always placing people who inject drugs at the center. They are in the room as we design our programming, as we prepare our NIH grants, and they are part of our IDEA staff. And frankly, the peers that deliver the teleharm reduction intervention are the key to our success. All I do is prescribe medication. The peers do the heavy lifting. So what is the teleharm reduction intervention? It's basically bringing care to people who inject drugs through technology. It is concierge medicine for people who actually need it. And so it's telehealth enhanced, peer facilitated, on-demand access to services. There's low barrier antiretrovirals, PrEP, medications for opioid use disorder, and direct acting antivirals for hepatitis C treatment. We're able to do mobile phlebotomy. We're able to do harm reduction counseling and medication management through those deliveries. We also have telehealth for mental health and substance use disorder services. And all of these interventions are delivered within the context of a syringe exchange program and integrated with the provision of evidence-based naloxone and injection equipment. We are truly meeting people where they are on their own terms and respecting their autonomy, which is fundamental to harm reduction. There are decades of evidence of this approach as being effective in primary HIV prevention. And in our pilot study, you can see of the 35 people who inject, I lost my monitor again. I will bring it back.
Challenges of hotel room talks.
Yes.
I've been there.
I was very excited though that I could mirror on my iPad. Oh, it's timing out. I will be able to bring it back. All right. All of that started with my good friend, Dr. Sirota, and his tricks. All right. So in our pilot, all 35 people who inject drugs were enrolled and completed a telehealth case management appointment with a Ryan White case manager. And all of them were able to complete a telehealth encounter with an HIV provider. And all of them received antiretrovirals on the same day. And we were able to report 78% viral suppression at 6 months. And this is the highest reported viral suppression that I've seen in the literature among people who inject drugs. So I will tell you more about that trial later. So changing state policy. So how did we do it? And this roadmap is very, very useful for people who are across more challenging political landscapes like the South. I know Alabama is very, very interested in implementing syringe services. And I hope that people are able to follow our roadmap. I feel for people advocating for public health in the post-pandemic world, but we are here to assist and provide technical assistance. Luckily for you all, Georgia moved the same year that we did, 2019, the last year of public health. So we've had successes using localized data and advocacy through students because legislators love to hear from students. And so this is in-person, phone calls, op-eds, We also have had testimonials from mothers who have lost their children to overdose. And we've used tailored messaging. So when we visit with Democrats in the Capitol, we talk about decreasing the number of HIV infections, reversing overdoses. And you can see down here when we met with people on the other side of the aisle that we talked about the cost savings. We had many challenges in passing our legislation. So the Republican majority, supermajority in Florida, caused changes in the way that the legislation was written. But we had some wind at our sails because the Trump administration, with the Ending the HIV Epidemic initiative, highlighted syringe service programs, syringe exchange, as a cornerstone for the prevent pillar. And I just like to read this quote. So this is from Senator Bradley, an extraordinarily conservative senator who became a key ally for us. And he said, "I just want to say, when I started my career in the Senate, I voted against the pilot project, and I was wrong," he said as he voted for the bill this time. And the results speak for themselves. It's very good public policy. So 2019 was a fantastic year for people who inject drugs and harm reduction community in Florida. We passed the Senate 40-0, and we passed the House 111-3. Governor DeSantis signed the bill on June 23rd, 2019. And there were several limitations to the policy. In the House, they inserted language that made it so no state or local funds could be used to operate our programs. It also prescribed that all programs must follow strict one-for-one distribution. And it also said that all counties must pass local ordinances in order to operate the program, so an opt-in approach. But this was still such a happy night. This is Dr. Bartholomew, who I've alluded to. This is Joy Fishman, a lovely, amazing advocate who lost her son, Jonathan, to opioid overdose in the early 2000s. And ironically, her husband also, Jack Fishman, was the man who invented naloxone. So we are working to support the counties in implementation using an implementation framework called EPIS: exploration, preparation, implementation, and sustainment. We've started the EPIC Idea initiative. So we have renamed it. So exploration, preparation, implementation, and collaborative sustainment, working with a group of individuals, a drug user-led organization called the Florida Harm Reduction Collective. We've been successful in implementing more programs statewide in Florida. So we've broken down the expenditures for the costs of those infections related to injection drug use that I alluded to in a prior slide. People are able to look at the appendix and see how much those infections cost in their individual county. We've also used machine learning to create a vulnerability assessment for our state by zip code. And we have developed individualized data dashboards, which include key elements like HIV and hepatitis C incidents, as well as overdose. And we have 6 syringe exchange programs in 6 of the 7 ending the HIV epidemic jurisdictions in Florida. We've had challenges in Duval County, but even though there's only 6 legal programs in Florida, I have to tell you that more than half of our state lives in these 6 counties. So we are very, very happy with the progress that we've been able to make. We also have 2 new programs, our first rural syringe exchange programs, and they are in Leon and Alachua County. So that's Tallahassee and Gainesville, those good college towns. So we're really excited for the rural implementation of these critical programs. So what is next? So back to teleharm reduction. So this is how we got 78% viral suppression. So the patient is always at the center. The peer harm reduction counselor brings the iPad to the patient wherever they are and connects them with me or one of my other colleagues. And we are able to prescribe medications, which could be antiretrovirals, medications for opioid use disorder, Epclusa, or any of the other pangenotypic hepatitis medications that we use. And they're all delivered to the patient with core harm reduction supplies, such as syringes and naloxone. And there's ongoing motivational interviewing through this process. And that's teleharm reduction, the peer being critical to the success. And under my Avenir Award, which is a DP2 from NIDA, we are leading the statewide rollout of SSPs. So we felt that we were the right people to lead this 3-site trial. So we have IDEA Miami, IDEA Tampa, and the SPOT, the SSP, the Syringe Exchange in Broward County. There are 80 people planned to be enrolled per site. We have 2 arms, either teleharm reduction or traditional or patient navigation into the traditional healthcare system. Teleharm reduction truly sets the traditional healthcare system aside and uses the SSP, our syringe exchange program, as an alternate venue. Our primary hypothesis is that teleharm reduction will be superior to patient navigation and HIV viral suppression across follow-up time points. And our secondary hypotheses are that teleharm reduction will be superior for initiation of buprenorphine and retention, as well as cures hepatitis C. And then in pursuit of sustainability, we are going to do a cost effectiveness analysis. And so that's Project T-Sharp, and we are in our 2nd year of randomizing in that trial. We adapted the teleharm reduction for medications for opioid use disorder. And so this paper was led by Dr. Eddie Suarez, our psychologist, and we had 109 participants who received the adapted teleharm reduction intervention. And our 3-month retention rate on buprenorphine was 58.7%. 2 key variables were associated with increased odds of retention. And so participants who saw a provider via telehealth at baseline or any follow-up visit, and participants who received an escalating dose of buprenorphine after baseline had a higher odds of retention at 3 months. And these are doses of 24 milligrams, 32 milligrams of buprenorphine. In the fentanyl era, we are giving much higher doses of buprenorphine. Participants who self-reported or tested positive for a stimulant, whether that be methamphetamine, amphetamine, or cocaine at baseline, had a lower adjusted odds of retention on buprenorphine at 3 months. So challenges to retention still exist, but we're developing new strategies to overcome these barriers, such as escalating buprenorphine dose and using telehealth. So in this adaptation of the teleharm reduction intervention into a status neutral intervention, where people are treated according to their needs and not identified by their diseases, we were awarded an R01 by NIDA for the Chariot trial. The grant was entitled In Pursuit of a One-Stop Shop, a Hybrid Type 1 Effectiveness Implementation Trial of Comprehensive Teleharm Reduction for people who inject drugs. And this was because of interviews we did with Black people who inject drugs at our program, who basically told us in our research under an Ending the HIV Epidemic supplement that they wanted everything in a one-stop shop. So we are going to simultaneously test the efficacy and optimize implementation of our intervention in diverse contexts, such as mobile and fixed site syringe exchange programs. Our primary aim is to evaluate our comprehensive teleharm reduction or one-stop shop approach desired by our community on both PrEP initiation and MOUD initiation and retention. Our cost effectiveness analysis and long-term clinical impacts will be led by Dr. Josh Barocas at University of Colorado, and the implementation science will be led by Dr. Tyler Bartholomew. And so with this teleharm reduction intervention, we seek to lay the foundation for an enhanced model of care for people who inject drugs to both treat and prevent HIV, transforming the way they access healthcare, and forging a pathway towards ending the HIV epidemic in this high priority community. A recent paper that we published looking at telehealth adoption in the first year of the pandemic found that 30% of syringe exchange programs nationwide reported implementing telehealth-based services. However, in multivariable logistic regression models, community-based organization as syringe exchange programs had a higher odds of implementation compared to public health department syringe exchange programs. And syringe exchange programs that received government funding had higher odds of implementing medical services via telehealth compared to those without government funding. So really,
hello, Miss Richard. Hello, how are you?
So this is a missed opportunity to engage a highly marginalized and long overlooked community. Telehealth really is a promising strategy to overcome this gap, but it needs to be tailored. It needs to be supported by tailored implementation strategies that match the diversity of programs, not only to enable syringe exchange programs to implement evidence-based interventions, but also sustain these interventions over time. In order to optimize these medical services, we need to promote best practices around HIV and hepatitis C testing in syringe exchange programs as well, especially in high areas of need like the US South. So based on national data, we see that adoption of on-site HIV and hepatitis C testing has been very, very high in syringe exchange programs. You can see here 87 and 71% respectively, but participant level uptake remains very, very low in this setting. This paper also showed that rural programs, smaller programs, and programs with smaller budgets were less likely to have implemented testing on site, showing significant gaps in equitable implementation across programs. So our current policies and procedures on how to HIV and hepatitis C testing is to be offered in syringe exchange programs fails to support the widespread reach by optimizing participant level uptake. So in February 2023, the CDC endorsed our opt-out approach to HIV and hepatitis C testing, adding it to the compendium of evidence-based practices and making it the only structural intervention to increase HIV testing in people who inject drugs and the only intervention in a syringe services program or syringe exchange context. So what is opt-out? So our policy is to screen folks for HIV and hepatitis C at enrollment and provide culturally appropriate linkage to care. People may decline, but delivering testing in a setting of trust has yielded promising results in Florida. So the question is, how do we equitably scale up opt-out testing? And so this brings us to our new, well, we received the JIT. I'm not going to say anything. We returned the JIT to NIDA, but we are very hopeful for this new RO1, which is Project Access, advancing equitable access to HIV and hepatitis C testing through structural transformation in syringe services programs. This will be a cluster randomized trial at 32 programs nationwide, and we are very hopeful that we will be receiving the notice of award soon. Very optimistic. So following the expert recommendations for implementing change, we hope to launch this trial next year. Now, we pilot tested our access implementation strategy at 4 of the newly sanctioned syringe exchange programs in Florida and found that all of them adopted our opt-out testing policies, and 12-month HIV and hepatitis C testing reach was over 90%. And so there are 2 components of our access strategy, and they are very straightforward, just like the rest of our research portfolio. Strategy 1 is accessing new funding. Syringe services programs, or syringe exchange, have been historically underfunded to implement best practices. In partnership with Gilead Focus, we will release $2 million of funding to syringe exchange programs to promote the adoption of opt-out testing. We're very, very excited about that partnership. And interestingly, this grant will make us one of the largest funders of syringe exchange programs nationwide. Strategy 2 is practice facilitation. This is iterative problem solving and working through barriers and facilitators to promote fidelity to our intervention and sustainment. This will be done in partnership with national partners such as NASDAD, the National Association of State and Territorial AIDS Directors, the North American Syringe Exchange Network, and AIDS United. And the intervention will be delivered by a team that includes people with lived and living experience, which is a key component to all of our work. Our primary effectiveness outcome will be participant level reach of our testing as we seek to optimize uptake of testing in this non-stigmatizing, optimal setting to promote the health of people who inject drugs. So there you have it, our 3 signature trials that seek to redefine HIV and hepatitis C testing, prevention, and treatment in this high priority community. We're really aspiring to transform the way that people who inject drugs access healthcare. And I have had just a tremendous support in my career, first and foremost from the participants of IDEA, who are just wonderful loving people, and it's so amazing to have the honor to care and advocate for them. I have partnership of amazing faculty at IDEA, Dr. Sirota, Dr. Bartholomew, Dr. Seraldo, who came to us from UCSF, and Dr. Chung, who trained with us. Lisa Metch, who is my career and life mentor, Dean of General Studies at Columbia. She has been so instrumental to all of my career decisions and life choices, and I'm eternally thankful to her. The partnership with my old foes, the Florida Department of Health, as we've moved forward to really do the good work in a really challenging political climate. I have to thank the University of Miami Miller School of Medicine for supporting a student to skip class to go to Tallahassee and then finally bring his classmates with him, and just allowing me to lead the substance use disorder curriculum and really teach it from a harm reduction lens, and to operate a syringe exchange out of a medical school. And of course, that all comes under the leadership of my dean, who is a phenomenal mentor. And I'm very thankful to all of the support that he has given me and the IDEA program. So thank you so much for listening. Sorry about the technical difficulties. I'm open to any questions you might have.
Thank you so much, Hansel. That was fantastic. I think it's just inspiring, and I'm going to pick your brain a lot. But Dr. Law, I think you have a question.
Thank you so much for this presentation and for sharing the journey of this incredible program. And I really loved how you shared the impact of advocacy, and especially the impact that learners can have in advocacy. I would love to hear a little bit more. Sometimes it's easy at this point to look back and say, wow, that's all incredible, what they accomplished and what they published and what they did. I'd love to hear from your perspective, how do you manage setbacks? And do you have an example of a particularly dark setback or discouraging time, and how you pivoted or refocused or redoubled your efforts with you and your team to keep going?
Thank you so much for your comments. And there were many setbacks yearly. And there were particularly dark setbacks as well. In our second year of running the legislation, we actually passed both chambers. So we were almost headed to the governor's desk, but there was one change in the legislation when it passed the Senate. So ultimately it did not reach the governor's desk. So being that close and then not being able to bring it home was particularly challenging. And our legislature works in 8 weeks, and then it's over, and you have to regroup, recover, and try again. I will say the biggest disappointment, and I will share this with all of you, when I flew back to Miami after only being able to pass a pilot for Miami, when initially we had intended to pass syringe exchange for the state, I was devastated looking down at Florida. I felt that I had failed our state, and that, that I had failed our state, frankly. But when we descended over Miami and I looked down at our city and I realized that we were bringing syringe exchange home, it just completely re-energized me. And then we led to the rigorous implementation and statewide analyses. And 3 years later, we were able to bring it to the whole state.
Thank you. Thank you so much for sharing that. I think it always helps, especially since we have so many people on this call that are engaged in the uphill battle of advocacy. And I think sort of seeing the setbacks and seeing that you can recover from them is really meaningful. Thank you so much.
Thank you.
Also, I want to ask you, we've tried many times to really use mobile units effectively. And, we live in a setting where we have to have financial justification for everything, right? And how have you managed to sort of I know you've done a lot through grants, but eventually you have to be able to scale and make this standard of care. How do you figure out the scenario to actually get reimbursed such that this can actually be a sustainable intervention for a healthcare system?
Yeah, we were really lucky at the beginning. Since we were the only program in Florida, there was a lot of national interest in making sure we were successful. So the grants came in. We taped together, $20,000, $50,000 grants in order to operate. But we did have to move towards sustainability. And that came very much for us in the form of being able to bill for Ryan White services, being able to bill for under the state opioid response contracts that we have in order to treat people for opioid use disorder, and then finally moving into a 340B context. So now our program has 340B, and it's very challenging with all of the rules, like being able to bill from a van, particularly with the physician not there. But all of the telehealth capabilities that we had during the pandemic have really supported our ability to bill for telehealth. I'm not sure yet whether or not we're cost effective. I will let you know as the papers come through. There's a lot of work that goes into supporting our folks and taking their medication. But we have definitely made moves towards looking at sustainability through billing for services at the SSP for those individuals who have coverage. Of course, those individuals who don't have coverage, we offer the programs, all of the treatment free of cost.
Thank you. We are at the top of the hour. Yes, you are in a similar non-Medicaid expansion state, which is why I was particularly curious how you work this together. Thank you so much, Dr. Tukes. This was fantastic. I always learn from listening to you and get rejuvenated that we can actually make progress on the many challenges that we have, not just HIV, but really, again, through multiple stigmatizing situations and vulnerable and social determinants and vulnerable patients. So thanks so much. I appreciate it.
Yeah, thank you so much for having me. I see Dr. Farley's here as well. Hi, Dr. Farley. I really appreciate talking to you all at Emory. Really special place in my heart. Thank you so much.
Thanks.